Good evening to one all present here. Recurrence is not a new term in uveitis. Focusing on controlling the inflammation and trying to find out the etiology, we often fail to realize the visual and physical impairment that the disease has left with. Despite adequate treatment of the complications, there is a residual visual impairment which can be benefited by the low vision aids. Hence, we did a study to assess the clinical profile and rehabilitation of the uveitic patients with low vision. With the objective of assessing the cause of visual impairment, the low vision device prescribed, and the visual improvement with it. Coming to the materials and methods, it was a retrospective observational study which was done between June 2019 and June 2024 in all the patients with uveitis referred to low vision clinic. We included inactive uveitis with low vision and a minimum of 6 months of follow-up, and excluded 15 patients due to active uveitis data gaps or inadequate follow-up. Coming to the visual acuity conversions, the distance and near Snellen visual acuity were converted to logMAR, whereas the near vision assessment during the low vision device was standardized to 32 centimeters using a table. Supposing this is the viewing distance and this is a logMAR and N notation, based on this table, if a patient has N6 at 10 centimeters, it will be equivalent to N20 at 32 centimeters, which gives us a logMAR of 0.35. Coming to results, the mean age of the population was 53 years, with 53% of them being females, whereas in other reports, it has been 21 to 30 years with a male preponderance. The main cause of the low vision has been macular scar in 51% and optic atrophy in 21%. On reclassifying the corneal scar and occlusio pupillae as anterior segment causes and ERM, macular scar and subretinal fibrosis as the macular involvement, we can see that macular involvement accounts for 62% of the low vision, which is similar to many other reports which also say macular involvement is the leading cause of visual impairment. Pan-uveitis accounts for 53% of the uveitis and posterior uveitis for 40%. Similar to the Kyangte et al. Report, pan-uveitis has caused a statistically significant severe visual impairment, whereas intermediate uveitis has caused more of mild and moderate visual impairment. According to the ICD-11, the patients were classified from grade 1 to grade 6, giving us a total of 22 patients who were visually impaired and 8 patients blind. For distance, the low vision devices prescribed include Max TV in 2 patients, binocular telescope in 2, monocular telescope in 1, and best glasses in 7. For the near, Prismosphere was prescribed for 7 patients, half-eye spherical glass in 6, sliding pocket magnifier in 3, and the others include handheld magnifier, video pocket magnifier, and best glasses. Not just optical aids, we also gave them non-optical aids like mobility cane, Notex, needle threader, and letter writer. Coming to the analysis, we analyzed the patients based on the segment of the uveitis involved with the low vision device and the improvement. And we can see that half-eye spherical glass and Prismosphere were the most commonly accepted near vision devices, and the visual improvement in pan uveitis and posterior uveitis was statistically significant for both near and distance. Similarly, on analyzing the cause of the low vision with the low vision device and the visual improvement, macular scar patients accepted Prismosphere and half-eye spherical glass equally, and the visual improvement was statistically significant in macular scar patients and optic atrophy patients for both near and distance. Our study is different from the Sarika et al. Report in that the most common distance low vision device prescribed was Max TV and binocular telescope in ours, and monocular handheld telescope in theirs. On analyzing the visits and referral time, though the average number of visits to hospital was 21, to the low vision device clinic was only 1.36. Less visits indicate less awareness and less follow-up assessments. Similarly, the mean duration of follow-up to the hospital was 28.58 months, where the referral was done only at 16.7 months. So maybe an earlier referral could have led to a better acceptance. The pros of our study was that recent LVDs have been considered, and holistic spectrum of etiology and visits and referral time have also been analyzed. The cons being the retrospective nature of study with a limited sample size, and compliance and quantitative assessment has not been done. So adequate treatment and a timely referral is the key to improve the quality of care. A collaborative study with a larger sample size can help us analyze the low vision device acceptance and create an algorithm for prescription of the same. Last but not the least, what matters is that we understand the silent struggle faced by the patient and encourage low vision device usage. Adequate treatment keeps hope in sight. Please refer to low vision clinic and give vision its right. Thank you.
Presented. Just need to ask, what is the mean visual acuity or the acuity where you had these patients? Because most of the time the acceptance of the low vision aid is dependent on the kind of acuity
Acuity.
and the kind of lifestyle that the
Profession,
patient,
the
yes,
occupation.
yeah.
Uh,
I mean, it's
Ours is
usually not
mostly
disease centric, it is usually patient need centric.
centric. Yes, ma'am. I totally agree with that. We referred patients who had more worse than 6 by 18, and 50% of them were actually unemployed. Our population caters to mostly an elderly age group. About the average age was 53 years, whereas in other studies it has been around 21 to 30 years only. So that's why maybe because they are little elderly patients, the acceptance of the device was also less. The distance low vision aids were given only for 12 patients out of the 30 patients. And that too, only like Prismosphere and near were accepted only by 13 patients, the near vision aids.
So I,
Activity that you do. Yeah, sure. Thank you.